This is Chris Fordyce, DCRI Fellow, and we're here at AHA 2014 in Chicago. I'm just here with Dr. Dion Stub, who will be presenting the AVOID trial, a trial of oxygen versus air in acute ST elevation MI. He's from the Baker IDI Heart and Diabetes Center, as well as St. Paul's Hospital in Melbourne and in Vancouver, Canada, respectively. Dr. Stub, welcome to the DCRI booth.
Thanks, Chris. Pleasure to be here, having a great time in Chicago.
Perfect. Can you tell me a little bit about the background in terms of the trial and what brought you to do this trial?
Yeah. So I think, Chris, as you'd remember from very first days of medical school, and likewise the same for first aiders and nursing and paramedic students, we're all taught that routine oxygen therapy is a fundamental first aid response to patients with suspected acute myocardial infarction. And it's really been like that for over 100 years, where almost as a reflex we give patients with suspected AMIs routine oxygen. And it's interesting when you actually try and tease out the evidence that there's not very much or certainly very good clinical evidence to support that practice. And maybe more concerningly is that there's this growing body of physiological evidence to suggest that there could be adverse effects to rendering patients hyperoxic or with high oxygen levels. So I think everyone agrees for those patients that are hypoxic need oxygen, but the question is, should this be routine practice?
Right.
And there have been some nice physiology studies to show that as little as 15 minutes of oxygen via a face mask can quickly cause hyperoxia, and that can lead to coronary artery vasoconstriction, reduction in coronary flow, increased free radical production, and all potentially causing increased reperfusion injury. And so on that background of questioning our current practice, that we wanted to know what its effect on myocardial infarct size in patients who were non-oxic with STEMI.
Great. And so tell me a little bit about the trial design and maybe types of patients you included, and perhaps how many patients were included in the final results.
So look, a key feature of the trial was that it involved both pre-hospital and in-hospital care. The trial was coordinated by Ambulance Victoria, their research division, and so all patients were randomised in the pre-hospital setting. So the inclusion criteria for the trial was that you had symptoms suggestive of a STEMI for less than 12 hours, that you had a pre-hospital ECG that the paramedics thought were indicative of ST elevation MI, and then that you were not hypoxic. And for this trial we defined a conservative level of 94%. So if you had an oxygen sat of greater than 94%, then you were randomised.
So no
by
heart
the
failure, no shock.
Yeah, so that's interesting. They weren't exclusions.
Okay.
So there were 5% of patients who had a diagnosis of eventual cardiogenic shock.
Right.
But if the paramedics could achieve a good sat trace,
right,
and the patient, and the other major thing was the patient had a preserved conscious state.
Okay.
So really, if they had normal conscious state and a SATs of more than 94%, and they were being taken to one of the 9 participating hospitals, then they were randomised.
Okay, perfect. So what did you find? How many patients were included in the end, and what are the results of the trial?
638 patients were randomised pre-hospital, but then when you teased out exclusions of those that were taken, a few were taken to non-participating hospitals, then many patients would arrive in the hospital, and as you know, with pre-hospital ECGs, there's a false positive rate, so the physicians would reassess the patient, and we had a number of patients drop out due to being diagnosed with alternative pathologies. So we ended up with 441 patients diagnosed with ST elevation MI, and they were the patients who underwent primary endpoint analysis, which was a co-primary endpoint of myocardial infarct size on cardiac enzymes, including CK and troponin I.
Right.
And so the findings of the study, the main primary endpoint study showed that when we looked at CK over the 72 hours, that there was a 25% increase in CK, both the peak and area under the curve, with a significant p-value of 0.01 in those that were given oxygen compared to no oxygen. So suggestive of increased myocardial injury. The troponin, whilst the curves were very similar, the confidence intervals were significantly greater with troponin, and it was a non-significant result. So really there was a non-significant 20% increase with with troponin. We then had a number of secondary endpoints. Interesting one was cardiac MRI was offered to all the patients on their return follow-up visit at 6 months. A third of the patients took up a cardiac MRI. So in 139 patients, we had a final infarct size on cardiac MRI. And again, that showed a very similar signal towards harm or increased infarct size in oxygen, a 30% increase in late gadolinium scar on cardiac MRI. When that was normalised for left ventricular mass, it was more of a trend. Again, this 25% increase, but with a p-value of 0.06.
Right.
So again, the study wasn't powered for major adverse cardiac events, but just as interesting that one, there was no change in patient symptoms. So patients didn't report feeling better with oxygen.
Right.
But there was increased recurrent myocardial infarction in hospital in the oxygen group, and clinically significant arrhythmias that required medical attention, both ventricular and atrial, were also increased in the oxygen group. So again, hypothesis generating that maybe this increased myocardial injury signal that we've seen from our trial might translate into harder clinical outcomes, but that certainly wasn't assessed in our trial with relatively small numbers.
Right, definitely enticing data. So do you think, what are the implications? Is this an implication, should we be doing more trials, larger study perhaps? Should we be, thinking about not giving our patients oxygen?
Yeah, so the easy answer is, look, this is a relatively small study, 441 patients. We definitely need a larger trial, and our Swedish cardiology colleagues are currently halfway through a large trial of oxygen in MI powered for mortality.
Okay.
And I think that will be a fantastic study that I'm looking forward to seeing the results. But even from this small study, relatively small, I take away that we really need to think of oxygen as a drug.
Right.
It clearly has efficacy in patients who are hypoxic,
right,
and is a potential life-saving measure, but maybe we should be prescribing it, and that we shouldn't indiscriminately give patients oxygen, which in physiology studies have been shown to be vasoactive, and our study shows a potential signal towards increased myocardial injury, and so that I wonder if it should require a prescription before that we just plough ahead with high levels of oxygen therapy in patients who may not need it.
Wow. Those are some interesting thoughts on oxygen. We definitely take it for granted, and perhaps we should be thinking about it differently in the future. So I just want to thank Dr. Stub again for joining us at the DCRI booth, and you can find more information at the Duke Cardiology Fellows blog.